Let me paint you a picture. You're 64 years old. You wake up and your head is clear. No fog, no dull ache behind your eyes. Your blood pressure reading looks steady. You take your morning pills, and for once, you're not wondering whether one of them is quietly working against you. You walk into your next checkup, and instead of just nodding along at whatever's on the chart, you ask one sharp, informed question, and you actually understand the answer. That's where I want to get you by the end of this video. But right now, the picture might look a little different. Maybe you're still taking the same painkiller you took at 40. Same brand, same dose, same bottle in the same drawer. Maybe that heartburn pill has been on your nightstand so long you genuinely can't remember starting it. And even if you're watching this at 52 or 55, and 60 still feels a few years away, this is exactly the kind of thing worth understanding now, before it becomes urgent. Here's the uncomfortable truth. The pill didn't change. You did. After 60, your liver clears medication more slowly. Your kidneys filter less efficiently. Your blood vessels aren't as elastic as they were 20 years ago. So a drug that was perfectly calibrated for your body at 45 can behave in a completely different way inside your body today. Same pill, same dose, very different outcome. Before we go any further, I need to say this clearly, because it matters more than anything else you'll hear today. Nothing in this video is a reason to stop taking any medication on your own. Please don't do that. Stopping a blood pressure pill, a blood thinner, or a heart medication abruptly can be far more dangerous than any side effect I'm about to describe. Everything here is meant to start a conversation with your doctor, not replace one. What we're looking at today are 5 groups of medications that deserve a second look after 60. And the 5th one is going to surprise most of you. It's a pill so trusted, so routine, that for decades it was handed to nearly every man crossing 60 like a rite of passage. Millions of people still take it every single morning without a second thought. By the end of this, you'll understand exactly why that guidance quietly changed, and whether it still applies to you. Stay with me. Because the plan I'm going to hand you at the end is the whole point of this conversation. The first group is almost certainly already in your medicine cabinet. I'm talking about NSAIDs, ibuprofen, naproxen, the pills you grab when your knee flares up after yard work, or your lower back locks up after a long drive. Here's what's actually happening inside your body when you take one. These drugs work partly by narrowing certain blood vessels and signaling your kidneys to hold on to more sodium and fluid. At 35, your kidneys handle that without blinking. But after 60, your kidneys already have less reserve capacity than they used to. So that same dose that once passed through you like nothing can now raise your blood pressure, cause swelling in your ankles, and strain your heart, especially with daily use. I want you to picture your kidneys like a highway system. At 40, you've got 6 clear lanes moving traffic smoothly. By 65, you're down to 4. Still functional, still getting the job done. But there's a lot less room for extra load. A daily NSAID is rush hour traffic on a highway that can no longer afford it. I think of a patient I'll call Marcus. He was 71, an avid golfer, and had been taking naproxen almost daily for hip arthritis. Same brand, same dose he'd used since his early 50s. Over about 8 months, his blood pressure crept up, visit after visit. Nobody connected it to the naproxen until we sat down and went through his full medication list, line by line. Once we shifted him to occasional use paired with physical therapy, his numbers came back down within weeks. Here's your practical takeaway. If you take an NSAID once in a while for a headache, that's not the concern I'm describing. The real risk lives in daily or near daily use stretched over months. If that's you, ask your doctor whether acetaminophen might be a safer everyday option for your specific situation. And check your angles at the end of the day. Puffiness that wasn't there before is worth mentioning. Now let's talk about something sitting in almost every kitchen cabinet in the country. The little purple pill, or the white one, or whichever color yours happens to be. Proton pump inhibitors, medications like omeprazole, genuinely help people. Nobody's questioning that. But there's a catch that most people never hear. These drugs work by shutting down acid production in your stomach. And that sounds like a good thing, right? Here's the problem. You actually need some of that acid to properly absorb magnesium, calcium, and vitamin B12 from your food. Take one every single day for years, and that absorption can quietly decline, almost invisibly. Low magnesium and low B12 can affect your heart rhythm, your bone density, even your baseline energy. And most people never connect those dots back to a heartburn pill. I had a patient, I'll call him Raymond, who came in complaining of an irregular heartbeat and chronic fatigue. We sent him to cardiology. Nothing structural, nothing dramatic on the scans. It was a routine blood panel that finally caught it. His magnesium was quietly, chronically low. The kind of low that builds over years, not weeks. He'd been on the same heartburn medication for nearly a decade, prescribed originally for a short flare-up that was never officially revisited. Once we corrected the magnesium and adjusted his dosing, his heartbeat settled down within a couple of months. Your practical move. If you've been on one of these for more than a few months, ask your doctor two specific things. First, can we move to the lowest effective dose, or even switch to as-needed use? Second, can we run a simple blood panel checking magnesium and B12? It's inexpensive, and it tells you something real. One important note, don't stop this medication cold turkey. Your stomach can rebound with even worse acid production afterward. This is a taper with guidance situation. Quick question before we move on. How many years have you been on a heartburn medication? Drop the number in the comments. I'm genuinely curious how common long-term use is among the men watching this. Group 3 hits closer to home for a lot of men over 60 who struggle with sleep. Benzodiazepines, the classic anti-anxiety and sleep medications. You might know the names even if you don't know the drug class. Here's the mechanism. These drugs slow down your central nervous system. That's literally the point. Less anxiety, easier sleep, a quieter mind at 11 o'clock at night. And they work by boosting a calming brain chemical called GABA. But after 60, your body metabolizes these medications more slowly than it once did, which means the drug stays active in your system longer than you think. That grogginess the next morning isn't just tiredness. In many cases, it's the medication still working, hours after you assumed it was finished. And that matters more than it sounds like, because slower reflexes and reduced balance mean a real, measurable increase in fall risk. I've had more than one patient describe a fall the same exact way. I felt fine, I just misjudged the step. That misjudgment is often the medication, not clumsiness, and definitely not just age catching up with them. These drugs can also blunt your breathing rhythm during sleep, which is a real concern if you already deal with sleep apnea. So what do you actually do? Start by talking to your doctor about non-drug approaches, a consistent wind-down routine, short-term cognitive behavioral techniques for sleep. These can meaningfully reduce your reliance on the medication over time. And if reducing the dose becomes part of the plan, that happens slowly, over weeks, with guidance. Stopping abruptly can trigger withdrawal that's genuinely worse than the original problem. If you're currently on one of these, never combine it with alcohol, not even a single glass of wine at dinner. And pay attention to how steady you feel getting up in the night. Unsteadiness on the way to the bathroom at 2 a.m. is information, not just an inconvenience. Group 4 is one almost nobody thinks of as risky, because you can buy it without a prescription, sometimes right next to the candy bars at the checkout counter. Decongestants. Specifically the ones containing pseudoephedrine, found in many popular cold and flu combination products. The mechanism is right there in the name. These medications constrict blood vessels to shrink swollen tissue in your nose. The problem? They don't just work locally. They constrict blood vessels throughout your entire body, which can raise your blood pressure and add real load to your heart, often within the same day you take them. And here's the part that catches people off guard almost every time. Many cold medicines combine a decongestant with a pain reliever and something else entirely. You can end up taking more of an ingredient than you ever intended without realizing it. So before the next cold season hits, actually read the label. Not just the front of the box, the full ingredient list on the back. If you have high blood pressure or any heart condition, ask your pharmacist for a decongestant-free version. They exist. And for most people, saline spray, a humidifier, and extra fluids take the edge off congestion without touching your blood vessels at all. I've seen this one sneak up more than once. A patient with well-controlled blood pressure comes in worried because his home reading suddenly spiked. No obvious reason. 9 times out of 10, the culprit is a cold and flu combo sitting in his system, taken without a second thought. A stuffy nose is miserable, I get it. But there are gentler paths through a cold than reaching for the strongest thing on the shelf out of habit. Okay, 4 down. 1 more to go. And it's the one that's going to surprise you most. But before we get there, I want to pause on something important, because it's the point most videos like this skip entirely. Everything I've described so far isn't a universal danger list. It's a starting point. Your kidney function, your other medications, your family history, even how much water you drink in a day. All of it changes how these drugs behave inside you specifically. There's also a genetics piece here that most people don't know about. Your liver breaks down medication using a set of enzymes, and the speed of those enzymes varies from person to person, sometimes significantly. 2 men, same age, same weight, same prescription, can process it at noticeably different speeds. Neither one is doing anything wrong. That's just biology. And it's part of why a general list can only take you so far. Which brings us to number 5. For decades, this was recommended almost automatically. Turn 60. Add a baby aspirin. Protect your heart. Simple, right? Except the research has shifted, and the picture is more nuanced now than it used to be. For someone who has already had a heart attack or a stroke, daily aspirin still matters. It should absolutely continue under medical guidance. That's not what I'm talking about here. I'm talking about men over 60 with no prior cardiovascular event who started taking aspirin years ago as a general precaution, and whose doctor has never revisited that decision since. For that group, newer research shows that the risk of internal bleeding, particularly in the stomach or brain, can actually outweigh the modest preventive benefit. I think of a patient I'll call Walter. He was 63, had been on daily low-dose aspirin for 15 years. No heart attack, no stroke, no significant family history. He started it back when it was standard advice for basically anyone crossing 60. Nobody had ever brought it back up. We sat down together and actually ran the numbers. His cardiovascular risk, his stomach history, his current medications. In his specific case, the bleeding risk had quietly overtaken the benefit years earlier, and nobody had noticed. Not because anyone was negligent, just because a decision from years ago was never revisited. That's not a story about aspirin being dangerous. It's a story about a decision that was made once, and then left on autopilot. If that sounds familiar, that conversation with your doctor is overdue. Not an emergency, just overdue. Here's the piece I promised you at the start. At your next appointment, ask your doctor this, and you can use these exact words. Do I still need to be on this medication at the same dose? And has my personal risk changed since we last talked about it? That's it. Most doctors genuinely welcome that question. It shows you're paying attention, and it gives them permission to reconsider a decision that may have been made years ago and simply never revisited since. Write it down, put it in your phone. Say it out loud before you walk in so it's ready when it matters. Between appointments, you're not powerless. Your body is already sending signals. Most men just aren't sure what to listen for. Unexplained fatigue that doesn't match your activity level. Shortness of breath on stairs you used to climb without thinking. Dizziness when you stand up quickly. Changes in how well or how poorly you're sleeping lately. A gradual drop in grip strength or in how far you can walk before needing a rest. None of these automatically point to a medication problem, but they're exactly the kind of details worth bringing up at your next visit, instead of quietly writing them off as just getting older. Bring them up. Don't wait to be asked. Here's one more number worth knowing. Once you're regularly taking 5 or more things, and that includes over-the-counter medications and supplements, the odds of a meaningful drug interaction climb sharply. Not double, not triple, sharply. And most of those interactions don't show up as a dramatic event. They show up as fatigue that gets blamed on age, dizziness that gets blamed on age, a slow, quiet decline that everyone just assumes is what happens after 60. Sometimes it is just age, but sometimes it's 5 medications quietly working against each other, and nobody ever sat down to check. If that's you, ask your doctor specifically about a full medication review. Bring in every bottle you take, or just photograph every label on your phone the night before your appointment. It takes 5 minutes, and it routinely catches things that would otherwise slip through for years. Before we wrap up, I want to hear from you. Of the 5 we covered today, which one surprised you most? Was it the aspirin, the heartburn pill, something else entirely? Tell me in the comments. I read every single one. And if this video helped you connect some dots, Subscribing helps more men your age find the same information. I'm covering the next part of this puzzle soon, specifically how to prepare for a medication review, so it doesn't feel rushed or like you're wasting your doctor's time. I also have a video on how to read your own blood work without needing a medical degree to decode it. Link is in the description. Here's what I want you to walk away with today. This was never about fear. It was about walking into your next appointment a little more informed. Asking one sharper question, making sure the medications that once protected you are still the ones actually helping you now. Your body at 65 is not your body at 45. That's not a failure. That's biology doing exactly what biology does. The medications that once served you deserve the same attention you'd give a car with 100,000 miles on it. Not panic, just a proper checkup before something small quietly becomes something bigger. I'm Dr. Adewale. Take care of yourselves, and I'll see you in the next one.